Hi, everyone. This is Randy Hausman with Becker's Healthcare. Thank you for joining us for today's webinar, Prime Healthcare's Blueprint for Team Model Readiness. Before we begin, I'll walk us through a few quick housekeeping instructions. We'll start today's webinar with a presentation and we'll time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and it will be available after the event. You can use the same link you used to log into today's webinar to access the recording. Finally, if at any time you're having trouble with your audio or your visuals, please try refreshing your browser. You can also submit any technical questions into the Q&A box. Our team's here to help. With that, I'm pleased to introduce today's speakers. Dr. Ahmad Imran is the Vice President of Value-Based Care and Quality at Prime Healthcare. With an MBA in Healthcare Administration and past experience as the President of the California Association for Healthcare Quality, he specializes in driving performance improvement and innovative care models to better patient outcomes. His passion lies in driving innovation in healthcare delivery and engaging in community health initiatives. We're also joined by Dr. Mansoor Ali Khan, the CEO of Persivia and the visionary behind the AI-powered platform CareSpace. This platform serves over 200 hospital systems, 18,000 providers, and 20 million patients. As an MIT-trained scientist and serial entrepreneur, he has built multiple healthcare technology companies, including Diagnosis One and Alere Analytics, which was acquired by Abbott. Under his leadership, Persivia has secured funding, grown rapidly, and expanded globally. Thank you, Dr. Imran and Dr. Khan, for being here today. I'll now turn the floor over to you to get us started.
Well, thank you so much for the introduction, and thank you. Hope we're going to have great sessions. So I'd like to have this one more of an interactive session as we go along. So what we like to discuss today is, along with Dr. Mansoor, we at Prime also has BPCI, CJR, and other value-based models. As you all know, there is a new team model that is going to kick in from January 1st, 2026 discharges. The challenges which we think or perceive for that model, our capabilities with Persivia, how we have developed our framework around those ones, and towards the very end, some discussion and question answers. So I'll highly encourage also to please do ask us questions so we can give you the best information we have so far. As you may know, I'm Ahmad Imran. I'm the Assistant Vice President for Quality at Prime Healthcare. My background is I'm a physician along with a master's in business, been with Prime for quite some years. At Prime, we are California-based organization. We have our presence in 51 hospitals across 14 states. We have 360 outpatient clinic locations. On an average, we have pretty much more than 2.6 million patient visits each year. And like I briefly mentioned earlier, we also do participate in a lot more value-based programs with the CMS. We have our own ACO Reach in multiple states. The quality, different episodic models with the CMS, CJR, BPCI, to name a few. So I'm going to pass this one on to Dr. Mansoor so he can give you an idea about Persivia and how our partnership has evolved in these years. So Dr. Mansoor, all yours.
Thank you, Dr. Imran, and good morning or afternoon, everybody, depending on where you are. It's a pleasure to be speaking with you, and thank you for taking the time to visit with us today. So I'm one of the founders of Persivia. Persivia has been around for a little over a decade now. We've been doing AI since before AI was a thing, and we've built a single platform that is designed to support multiple value-based care initiatives at large, complex organizations. So a typical client for us will have multiple ACOs. They will have Medicare Advantage lives, commercial risk arrangements, bundled payment, Medicaid risk. So very complex business environment, and you're operating across tens of different EHRs and payer data feeds going in and out of the organization. We serve over 200 hospitals, over 12,000 providers, and over 20 million patients today. And we have a very strong patented process that is built into our platform, which is called CareSpace. We've been collaborating and partnering with Prime for over a decade now. We started off by helping them with clinical quality management, so both the eligible provider and eligible hospital quality analytics and reporting, all of the data aggregation, data collection, data cleanup that goes with that. Then as Prime moved into value-based care, starting with the BPCI and CJR programs, we supported those. We also support Prime's ACO, and we'll be supporting Prime with their team's implementation. So that's the power of the platform, is that a single platform supports all of these initiatives across data management, care management, quality management, cost and utilization management, and risk management. And all of these capabilities have been deployed in Prime now for going on close to a decade. So again, a pleasure to be speaking with you, and looking forward to a very interesting discussion and learning from Dr. Imran about all the stuff that they have gone through over the last almost a decade now. Over to you, Dr. Imran.
Thank you so much. So as you all know, the team model gonna start pretty soon, but to bring everyone to speed, what's the objective of the CMS likes to do, and what is the goal? So the objective is to make sure we drive accountability for cost, making sure the program meets the CMS guidelines from cost and also the quality of care. So even though the cost is the crux of the program, but also making sure at the same point there is no compromise for the quality, and the goal is to reduce the cost while improving the outcomes. We're going to speak also later that with different composite quality scores, how they're going to adjust with the model, what is their impacts going to be on the model with the team program, and what we have learned with other value-based models, how we can incorporate those ones in the program. So to start, as you all know, the program is going to kick in January 1st discharges from 2026, and it's going to go to 2030. That's the last year. Few important things about this program. Again, it is a mandatory model. The hospitals got selected by CMS, and it's each year or performance year is one calendar year that coincides with it. The beneficiaries are traditional Medicare patients. Those are fee-for-service, and they will auto-enroll or get auto-enrolled in the program based on clinical episodes. Those are listed here on the bottom of your screen. So those are coronary artery bypass or CABG procedures, major bowel procedures, lower extremity joint replacement program, or procedures around those ones, surgical hip and femur fracture treatment, and spinal fusion. So any traditional Medicare patients who gets admitted in an hospital, who's an anchor hospital, have those episodes, will got auto-enrolled in the program. One big fundamental change which you see in this model compared to the other BPCI or the traditional CJR models, those models ran for 90 days post-discharge. This model is 30 days post-discharge. So I think this is a big fundamental change you see in this program compared to the previous models. The other important thing, like other value-based model, what the CMS has done is creating some safeguards around the program. They have federal anti-kickback statute programs and safe harbors protections for the program. Here, I can openly talk with the physician, with the providers, and say, hey, let's work towards this program, making sure we have a cost containment while not compromising the quality of care, and work towards, again, if there is a gain, we can work together, we can share the gain, and that's the best way to work this program. The contracts work again between the provider and the hospital. The way it works is based on your agreement. If there is a gain, the gain could be shared with your downstream partners, and you can split the payment. That will be incentive for those providers to make sure they are aligned with your philosophy. One thing I can point out, which we learn in our value-based programs, a lot of times there was a notion with providers or post-acute network that entering in agreement does not mean they're going to get a gain or they're going to gain share. So you have to have a gain in order to share that one. So I think that's important to make sure when the agreements are got in place, that there is a discussion around this, around the expectations of the contract as well. The program has going to have 3 tracks. Again, track 1 is year 1. It's going to be for all participants, as you can see here. Track 2 is going to be year 2 through 5. This is going to be for select hospitals, and track 3 is going to be for other hospitals. So we are going to speak in a minute. So track 1, year 1, all hospitals, that's going to be in the program. The good thing in track 1 is there is no down financial loss in track 1 or year 1. If there is a gain, it gets capped at 10% of the total cost of care. So the other important thing in this one is the quality score. Again, in year 1, there is no negative reconciliation if you're not meeting the quality goals. But if you meet or exceed your quality goals, there are going to be 10% reconciliation adjustment to your positive gain or your NIPRA or net patient reconciliation amounts. So track 1 is pretty good, or year 1 is pretty good in a sense. If I summarize, all hospitals are going to be in track 1, year 1. No down risk on financial, no down risk on the quality side. But if you meet or exceed, 10% will be your gain on financial side, and 10% will be gain on your composite quality scores. Now, track 2 will be year 2 through 5. Those are for hospitals. Those are going to be your community hospitals. Those are safety net hospitals, critical access hospitals, rural hospitals, and so forth. That will be in track 2. In year 2 through 5, the gain gets capped at 5%. The loss also gets capped at 5% for your financial risk. Regarding quality composite scores, again, 10% is your positive gain, 15% if there is a negative reconciliation amounts adjustments can happen for track 2 for these hospitals. Track 3 is for majority of the hospitals that do not fall in track 2, those ones. Again, for financial risk on those ones, 20% up and down. That would be your gain and loss. And then your quality scores get reconciled at 10% positive or negative gain. So that's going to be for each hospital, wherever they're going to go from track 2, track 3, from year 2 through 5. I think this is a more important one. Perhaps going to spend more time and more in discussion with Dr. Mansoor on this one. So these are a few of.
So Dr. Imran, if I may just add a little bit to, I want to just comment a little bit on the differences between the BPCI and the TEAMS model. The differences are subtle and not very big, but they span a number of different areas. So I just want to make sure that I just want to quickly touch on those to make sure that everybody is sort of aware of where those differences lie. So, so there's differences in participation, in episode focus, in episode length, in risk structure, care coordination requirements, quality metrics, health equity focus, etc. As I said, they're not very big differences, but they kind of span the full spectrum of your activities. So for example, for participation, BPCI was voluntary. In this case, it is mandatory for hospitals selected based, by CMS. On the episode side, the episode focus in BPCI was very broad. We had both structural and medical episodes. They were, if I remember correctly, 45 or so episode groups that you could select from. In this program, the TEAM program, it's a very narrow focus. There are only 5 surgical episodes, as Dr. Imran just sort of went through. The episode length is the big difference. Previously, it was 90-day post-acute. Now we're talking about 30-day post-acute. So it's a much shorter period that you're responsible for, and therefore your risk profile is going to be different. But that's something key to keep in mind. The risk structure is also somewhat different. It was much more flexible in BPCI because it was a voluntary program. It was mostly larger hospitals that were participating, and they had the resources to kind of manage a more flexible risk structure. In this case, it's a much more structured approach where there is no risk in year 1 and 2-sided risk with fairly tight limits of 10% generally, both on the upside and the downside. Care coordination was encouraged but very loosely defined in the BPCI model. But in the TEAMS model, it's going to be much more structured and auditable requirements. So SDOH, transitions of care, post-acute coordination, all of these kinds of things are going to be auditable by CMS. So having a strong infrastructure to manage care and provide care coordination and care management is going to be very important because it has to be traceable. And if CMS comes asking, you have to be able to demonstrate to them that the activities were performed. Quality metrics, quality had, sort of very modest quality adjustment requirements in BPCI, but these links are much stronger with the composite quality score now. And there's specific incentives and penalties tied to your quality scores, which was a much looser case in the BPCI program. Similarly, health equity, there was really no health equity focus in BPCI. Now there's explicit social risk adjustment, screening, optional equity reporting. So, significant areas, new areas to keep track of. There's even some initiatives around decarbonization and resilience support for climate change related activities. So overall, there's a number of initiatives that and areas that you have to be cognizant of. They're not huge differences, but they're significant when you add them up to be aware of, and so you don't run afoul of some regulation just because you weren't aware of it. So over to you, Dr. Imran.
Oh, thank you. Thanks so much for summarizing. Really appreciate it. That's very thorough differences in these programs. As you mentioned, they're subtle, but definitely is going to impact the outcomes and the financial gain on those ones. So I think what I want to share, these are important things that we have learned for different bundle programs over the years. I think the main important one, I just put this one on the extreme left in the red, is the care coordination. The care coordination is central for any of these programs. If you're not properly coordinated, that does not mean only acute, but primarily also on the post-acute side, meaning making sure you have a right provider who's going to be your partner, who's going to be your champion to lead the program. How you coordinate with your post-acute SNFs, rehab, and so forth, and making sure the care is appropriate for your patients. Your important one is also the data transparency, making sure whatever information you get from CMS on the claims and also the spend, you are transparent in your data share. There is a lag, of course, for the CMS. By the time the data gets posted, you will share, but you need to make sure you do a conscious effort on those ones, and there is some transparency in the data. The third is your post-acute care drives the cost. I think it's interesting, as we were in other bundle programs that ran for 90 days. I think everyone or majority of folks, when we go and ask where you think is most of spent, a lot of folks tend to think that spend on this patient is on the acute side. And as you all know, 70% of spend of these patients for 90-day episodic care is on post-acute side. So that's something illuminating for these folks to understand. Yes, even though it may not seem that way, but when you extend the care for 90 days, your post-acute spend is the main driver of the cost of care for these patients. Like I mentioned, your physician alignment is the key. You cannot have a successful program unless you have a successful physician who's going to run the program, who's going to lead the program, and follow up from physicians on the post-acute side, meaning you have a continuum of care. If you have the same provider or same group of folks who follow up on your patients on post-acute, I think that's an important key factor. Some risk adjustments in the gap of care, how you establish some quality guardrails in the program. As you all know, every CMS model that has money tied to it and definitely have some quality guardrails in this program. I'm going to speak about quality in the next slide. And then the important one, whoever you work with, either you have your own homegrown program or you work with anyone else, an outside vendor, you should have some kind of flexibility and customization about the program that will fit your needs. Because of course, every institution will be unique. Even within our institution, we are big footprint from state to state. We have some differences how to manage a post-acute and so forth. The other bigger challenge you also will see as the team model will kick in is the smaller hospitals also, or smaller providers, going to be a lot more admin block or burden for them. In this program I have seen, within our system, we have seen a small to mid-sized community hospital to all the way to bigger, large community teaching hospitals. So it's a spectrum of all the hospitals those are in this program. So the smaller hospitals, smaller providers are going to feel that admin burden, how to run the program. And again, you need to make sure it's aligned with other programs. I just mentioned ACO. For the reason being is because one of the mandate in this program, which you see in the team model, which we also learned from other bundle programs, is your post-acute appointments with your primary care physicians. So if your patients are getting seen in hospital, getting seen in ER, how you align with the PCP to make sure you have a right follow-up and you manage those patients appropriately, so there is no unnecessary readmissions and so forth. So I think this will we'll do a talk with me and Dr. Mansoor. So I'm going to share what we have accomplished so far as we with our BPCI or other value-based models. We were quite successful as a system. Our net patient reconciliation amount or positive gain was somewhere around 4%, more than a national average of 2.2%. We were very successful in decreasing the length of stay in SNFs, around 7% reduction. Even still, it is challenging. I still believe this is not where it should be, but we were able to move the dial. Took us some years to do it. We also were very successful in reducing the spend, and I think that was the main factor. As you will see, this program, your post-acute spend or your partnership with your post-acute providers is the main key, and then the accuracy as far as what you can predict, what should be my target pricing, and how much accuracy you have in the reduction of those ones. So these are our accomplishments. And then In what we hope for this one, and I'd like to share in this session, is how we can incorporate some of these gains, some of these experiences, and move those ones to this team model. The key factor, again, the total cost of care optimization, making sure your cost of care is appropriate. Post-acute network is the key, strengthening your post-acute network, making sure you have the right providers, meaning not only the physician, but if your patient is going to a SNF, if that SNF is the right SNF to partner with. We have established in the BPCI or other value-based model programs is SNF report card based on the claims data that tells, okay, if we're sending a patient to a particular SNF, what is the length of stay looks like in that particular SNF. If the patient is getting readmitted, why they're getting readmitted, at what point they're getting readmitted. A real feed, I think, which I'm going to speak in a minute with Dr. Mansoor, the interface with SNFs, with our EMR, how the data flows and how the information flows, and then focusing on the cost, especially with the risk adjustment, how you can predict if this is a high-risk patient, both from a cost or from a quality of care perspective. What is the likelihood of this patient of getting readmitted, or what will the cost look like on post-acute? So you'd like to add something, Dr. Mansoor, on this one?
Sure, absolutely. So one of the things, or one set of things that we found, as Dr. Imran mentioned, right, care coordination is a key initiative that, frankly, it's at the heart of success, either in BPCI or teams. And that has essentially two components. One is getting the data that is available in the hospital EHR and making sure that's available in real time, or at least no more than same day availability. So when a patient is being discharged, you want to make sure that you have the latest information from the EHR available, and then creating a care coordination network that encompasses all of the key long-term care facilities, primarily the SNFs that are likely to be taking your patients. So, for Prime, we created a care coordination network that had over 1,000 SNFs in it, and every one of those SNFs had access to all of the patient's data before the patient showed up. We actually put in a process where you had the ability for the discharge nurse to send out a notification to the likely SNFs and ask them to accept the patient and provide them enough information about the patient's record so they could make a determination if that patient was best suited for their specific skill set or not. So those kinds of initiatives involving the SNFs, getting them together, giving them access to the data, giving them access to information before the patient even shows up, had a big impact on some of these cost reductions and LOS reductions that Prime was so very successful at. And so as we go forward into teams, one of the things I think that every team participant really should look at is, which are the SNFs that are in my catchment area that are likely to be taking most of my patients. And there are many reasons why a patient may go to one SNF versus another, right? It could be a preference of the attending physician, it could be the patient's preference, distance from their home, family members, so it's a complex set of criteria that kind of go into that decision. But having a wide network so you can make sure that you can deliver the information to the appropriate SNF and at the same time get feedback back from them so you can monitor the patient and make sure that they are discharged when it is appropriate is key to success, both in BPCI and for certainly in teams as we go forward.
Thank you, Dr. Mansoor. And I think this is what the slide, perhaps we're going to spend a little more time. I think the one of the biggest challenge what we initially had in managing our value-based models, and perhaps some of the newer folks who's going to get into the team model, is to have a real-time visibility about your patient. So I'm sure every hospital who's going to be in a program will do an excellent care managing those patients. So We believe we manage our patients and did excellent job and within our four walls, but then we tend to lose our visibility when the patient leaves the hospital four walls, and then we are dependent on if this patient goes to like a SNF or inpatient rehab and so forth. So what is the real-time information you can get, how your placement would work? I think that's the main key as far as that the coordination goes. The other thing also important for over here is to make sure if you have it, see here in the middle of the slide, some kind of a risk stratification in a sense. Are we capturing the patient criticality the way it should reflect in the record? Because you'll see in your model, with joint replacement, especially like 469, 470 DRGs, 1469 is with CCs, with MCCs, and 470 with no MCC. So is the patient has any MCCs or major comorbid condition, and that will drive the care of the patient, and that will drive the cost of care for that patient. So just an example how important your case mix index will be, or your documentation will be, is if you look, and it's an average, each area is going to have a slightly difference in the target pricing, but for 469 DRG, when I look on some of these ones for 30-day episodic care, it's around $36,000 to manage those patients. Again, lower joint replacement. And then 470 DRG, pretty much the same, but without MCC, is 18,000. It's almost half of the cost. So, but if you're managing the patient same, or if you're not documenting this one, the patient has major comorbid conditions, of course your cost of care will go down, and your management will not go along how critical the patient will be. So I think that is important to make sure we document every clinical condition that is there, every comorbid condition that is there, so it could be appropriately coded and billed. I did initially speak about the real-time dashboards and alerts. I think that's important. What we learned on this one, and I think as you all know, in this model with the team, there is a requirement to make a post-discharge appointment with your primary care physician. So how you will know if that's your patient who is getting admitted, maybe somewhere that is not in your network, or after or within 30-day care, if that patient has gone to SNF and got readmitted somewhere else. So a real-time alert will help you to create some visibility, so at least you can reach out to your physician. You can reach out if you are part of any primary care services, so you can reach out to them, have the patient seen by PCP and so forth. The good way we have gotten in certain markets is having either some kind of agreement with your HIE, so at least you can have more real-time data feeds to you and alerts, so you know where your patient is within the next 30 days once they have left your hospital. Your post-acute utilization will be key factor. Like I mentioned, I believe with the exception, we'll see how the program will evolve. But if you look on most of your clinical conditions or those get selected, or procedures that got selected for this program, with the exception of CABG, that's going to have, or open heart surgery that have got maximum inpatient spend. The other procedures going to require your post-acute spend. Your ortho procedures is going to require a lot more extensive rehab on those patients and so forth. So how you going to manage, how you're going to make sure you stay within the CMS parameters of the length of stay and cost optimization. The quality management, again, like I mentioned earlier, they're going to be up-down risk. If you have a gain, CMS will put that 10% of the money on the side to see if you meet or exceed your quality matrices. As any CMS programs, they are very focused on the quality outcomes. For this program, they're going to look at your readmissions, they're going to look at your PSIs, and they're going to look at your patient-reported outcomes. So if your PSI 90 composite in year 1, and then the other PSIs from year 2 onwards, your falls, making sure you don't have no issues as far as your PSI 4s and so forth. So these are important ones to keep track, because otherwise that 10% of quality withhold it become quite substantial when you talk dollars and so forth. And then the more important one, what we learn is working with any vendor. I think it's important to make sure you have a good support that will help you as a system, because any larger system, of course, you will require them to do some customization that will meet your needs. So if they are open to do an end-to-end admin support, they're open to that customization, I think that would be a good fit. And I think I'll have Dr. Mansoor speak to the very first top elements on the longitudinal care space and care points. So Dr. Mansoor, back to you.
Sure. Thank you, Dr. Imran. Yep. So, over the last couple of slides, Dr. Imran hit on some very critical points. Let me start with just sort of an overall retrospective view, right? So in BPCI, we saw that every year CMS reduced the target price. And that really started to squeeze margins, as we went further along into the program. And so in the beginning, the target prices were high and there was plenty of margin there to work with. But if an organization did not improve their actual processes, care delivery processes, then as the target prices started getting squeezed, the margins were gone and they ended up losing money. So it's critical to keep an eye both on your processes, but also on proper documentation, so you're getting the right case mix index and your target prices reflect the case mix that you're dealing with. So when you have sicker patients, high risk patients, you're getting recognition for that. So that's a critical piece, as it is in almost all of the value-based care models. But in this case, it is also very important because these are all very high cost episodes. So a small swing, 1 or 2% this way or that way, can make a big difference, especially when your net margins are on the average are only a couple of percent of savings. So 1% swing can take you from making money to losing money. But having said that, one of the areas where we initially struggled with but eventually solved and now have a good process for is making sure that we're collecting the data from all of the different sources, whether it's the HIE telling us where the patient went, it's extracting from Epic or Meditech the real-time information about the patient's history, delivering that into the ambulatory EHR for the PCP to follow up, making sure that their transitional care management visits are appropriate and they have the right information when that patient comes in for the visit. So all of these aspects of creating a single longitudinal record and then making sure you have both the input data and the output information to the ambulatory providers is accurate and appropriate are key pieces in sort of being able to manage your risk and deliver the quality of care that everybody wants to be able to deliver. And of course, if you have multiple programs, which most everybody does, so if you're doing, you're in team, but you also have an ACO, you have Medicare Advantage, you might have multiple ACOs. So then, bouncing between systems becomes impractical. So thinking of sort of how you're going to manage multiple programs, sort of in one environment is very important as we go further and further into value-based care. Now that more and more of these programs are getting mandatory. So those are some of the thoughts that I wanted to share on this specific aspect. Over to you, Dr. Imran.
Sure. Thanks so much. So I think this perhaps is the pinnacle, the crux of our presentation. So I think what we kind of listed the challenges again is more, I guess, the recap of our discussion so far. where we think perhaps your solution is going to be, if that's your challenge, somewhere in the center. And then how is this going to apply to the team program or team model? So I think we've been saying care coordination is your main key. I think that perhaps is going to be the main factor for a successful program. So care coordination, again, if I want to start this one from the scratch, starts from any time that the patient gets admitted to your ER, creating a flag somewhere into EMR for visibility to your staff or to your physician and say, hey, this patient belongs to a team model. Based on your working DRG. So it will show up in your census, in the physician tracker, anywhere where the staff knows, the physician knows, yes, that's my patient who belongs to team model, so we can care this patient appropriately. Start having discussions on the day one. How are you going to place this patient if the patient is going to go to a SNF? Who will be the good partner? What we learn from here is a lot of times you think is a good partner, turns out not to be a good partner or great partner. You have to have some kind of a tangible means of assessing it. Ours was SNF report cards along with physician scorecards. SNF report cards tell us everything from the claims data which we pulled. We got information, what is the spend of a particular SNF or a rehab on a particular patient for that particular DRG? What happens to the patient as far as the outcomes goes, if there is any complication that happened to the patient when the patient was in the particular SNF. So that's important. So you can utilize your own platform or any of those ones. For us, CareSpace, CareTrack was pretty well. It was a seamless transition. So again, pulling information from different sources to bridge your care coordination, care gaps on those ones. Claim lag, as you will all know, you will experience this one. There's gonna be a lag in the data that get processed, but again, establishing as close as you could real-time dashboards, so you don't get surprised at the end of the year. As you know, this model, you can have a reconciliation of the net patient reconciliation amounts at the end of the year, as opposed to some other bundle programs in the past, where the CMS has done reconciliation twice a year. So you get a preliminary target pricing at the front end that you're going to be specific to your hospital in comparison to your region to create some visibility. And then, once the year will end, the CMS will do another reconciliation with a look back, and perhaps a few months down the month. So let's say if it's just based on my experience, if your model year or calendar year end in December, CMS perhaps will take another 90 days or sometimes up to 6 months to do a reconciliation with their look back, and you don't want to get surprised during that time. So you have to have some visibility on your claims and see where you are, where the patient movement is, and if there is an overspend, where this one is. And like the same thing with the SNF overuse. Physician alignment is going to be your main key factor, making sure you have your physicians who align with you in the sense that you nudge these physicians so they can visit your patient if the patient is in a SNF, so they can appropriately manage and get the patient home in a timely manner if the patient meets the criteria to go home. Some kind of an AI model. We spoke earlier also. You need to have some kind of an idea from the start of the program. Okay, well, this is my high-risk patient based on certain factors which you factor in. What is likelihood this patient for getting readmitted, spend-wise? If this patient is going to go to a rehab, what we learned also, the patients get admitted, goes to the inpatient rehab, from there goes to the SNF, then go home. So that's an extensive stay. So here you're looking only 30 days post-acute span. And if you're taking all that resources within the next 30 days, it's going to be difficult to manage the program appropriately. Quality guardrails. Again, linking the program to your real-time outcomes. So you should have a program that talks about your readmissions. What we learned this one is making sure once a patient gets discharged, you have to have a PCP appointment. Sometimes just creating a PCP appointment is not enough. So then you need to have someone connecting the dots. Yes, if the appointment was made, did the patient actually show up or not? We have within our system 7-day follow-up with the PCP when the patient gets discharged. You can pull information out of UMR if the patient is out of your network. Again, looping in some HIE data somewhere you can have a real-time information where the patient movement happens and so forth. I mean, they're definitely gonna, you'll see a lot more platforms. They will perhaps do better in certain area, and certain platforms do better in certain area. But if you're gonna run a program for this extended period of time, we also learned is single one platform works better. That's why I think it's important when you have a dialogue. Is that vendor open to customization? Are they open to your needs and how they can cater to your needs? And then, as you all know, the program is going to have some competing priorities between your providers who care for that patient. That will be your physicians, that will SNFs and so forth. So how to tackle those ones, either in the form of creating some of your contracts in a sense where you do some gain share with your providers. That will be some incentive with them, and so forth. So you need to have some kind of multi-model support for this one. So at least address all these areas on those ones. And I think this is perhaps we're going to run pretty much out of time. So that's the summary in total, where I think I'll speak to one and have Dr. Mansoor speak to towards the Persivia capabilities. But again, care coordination is going to be your central piece. You need to have some data transparency. Your post-acute is going to drive your cost, and your physician engagement is critical. So I think those are main 4 key factors which you will encounter, and you need to have some processes around those ones. So I'll pass it to you, Dr. Mansoor, for summarizing it.
Yeah, so that was very interesting and educational, Dr. Imran. One thing I would add, I want to make sure we get to the questions, so I won't take much time. But one thing I want to add is that, at the heart of these models, bundled payment models, is the episode, right? It's not like you have a population, as in an ACO or Medicare Advantage model. You're managing that population, and you know that patient's history, and you've been tracking them for a while. You have a relationship with them. In this context, it's any patient that walks in the door that needs a knee replacement. They become your, that becomes an episode that you are now responsible for. So you may not have much history on them, or you may have history on them. So sort of getting a system that goes beyond your EHR, beyond the Epic or the Meditech or the Cerner, into other sources of data, brings that in, rationalize it, and puts it together. But then very importantly, presents it in an episodic view, right? So what we want to do is to track not a patient really, but an episode. So the ability to know which episodes are operational at any one point in time, are active at any one point in time, which ones are sort of still have positive expense, which ones are negative, so you're already losing money on them. Having a very quick and easy way to look at that, track the episodes, and then be able to drill down into any given episode and do what we call a storyline view. So with a single click, open up the episode and see, okay, the patient started here, was admitted here, this was the anchor admission. They stayed in, in the acute, in the hospital for so many days. Then they moved to this SNF. This was the length of stay. These are the activities that happen. So that kind of a view that is essentially in real time or very near real time is critical to managing all of these kinds of capabilities. So real-time dashboards that are designed to manage episodes, and of course tracking the patient from the acute to the post-acute and back into the home. All of these capabilities become critical in success for models like TEAMS. So I'll stop here because we're now past our speaking time, and let's open it up for questions.
Yeah, thank you so much for the presentation. For the audience, please feel free to continue submitting questions. We'll try to get to as many as we can before we hit the top of the hour. First question I have is for Dr. Imran. Can you please share if Prime had any opportunity to increase HCC and hence improve target price?
Yeah, I think that's a great question. I was actually reading the chat box, also gonna have my notes. So I think that's important. So like I said, ACC or a CMI. So ACC, of course, is going to apply to post-acute or on your ambulatory side, CMI on an inpatient side. But the reason I mentioned that one is important, critical, this one is because that's going to drive your adjustment to your target pricing. So CMS is going to give you some initial pricing at the start of the year. And then once they do a look back, some adjustment is going to happen based off your criticality of the patients. So that's why it's very important to document. And that's the reason I was mentioning those. One very critical piece, within a particular DRG, there are 3 DRGs, or within clinical episode, there are 3 DRGs. And you can see there is variation in the CMS target pricing because it will reflect the patient condition. So it's important. So what we do is we work out of the working DRG. We work with physicians. We have the clinical document specialists and so forth to make sure there's an appropriate documentation and have these cases reviewed by your chief medical officer, some physician who is going to lead the program.
Thank you. Next question is also for you, so I'll go back to you. Did you track complication rates in post-operative patients and associated increase in length of stay, ICU transfers, etc.?
Yeah, so we do, absolutely. So again, like for this program, CMS is going to look at your readmissions. CMS is going to look at your complications, hip and knee, and your PSI. So again, you need to track those ones in real time. Have some of these processes put in place. So some of those ones you will see as the program will evolve, maybe in your direct control, some of those ones maybe not in your direct control. So in the sense that readmissions, yes, there are a lot of moving factors, moving pieces to it, maybe not in your direct control. But what you can do to reduce your readmissions is you have to have a proper follow-up with your PCP, making sure the patient gets seen by the primary care. Making an appointment is great, but it's not great in the sense that the patient does not see a PCP. So either they have an office visit or some audiovisual follow-up with the patient, either in the TCM or any other way, where you have some interaction with the patient once they get discharged from the hospital. PSI is in the year 1 is going to be a PSI 90 composite. So you need to have some processes, those ones. And then your year 2 onwards, then you can have separated your falls, your PSI 4, and so forth. So those ones, you need to have some processes on those ones in place as well. That actually this is a true complication, it is an anticipated complication or not. So need to have some processes on those ones as well.
Thank you. We'll go to Dr. Khan for this next question. Is Persivia only available for hospitals? Is there a service for home health care?
No, it's available for acute, post-acute, ambulatory, sort of it's independent of the specific location of service. So yes, we can support you in the home health care also.
Thank you. Next question, Dr. Imran, we'll go back to you. I've heard there are 2 dedicated representatives responsible for TEAM at each institution. Do you know if this list of individuals will be populated by CMS? If not, what's the best method of identifying these individuals?
Yeah, I mean, the CMS is gonna give you which person, but I think the main key is you need to have a dedicated resource, starting from who's gonna lead your care coordination, who's gonna call these patients and do a follow-up. So anyone, a care navigator, could be clinical, could be non-clinical person who has good skills, who understand. In our best practice, I think perhaps a nurse will be a right resource, but again, we leave it up to each institution what they think. But a care navigator will be a key person who can connect with the patient, with the physician. Physician is a key role. I think one of the questions that kind of correlated with this one is how you make sure your physicians follow up on post-acute, is a specialist or not. So that's going to be challenged because some of these procedures, majority of procedures, is going to be your ortho procedures. So either you have a contract with your orthopods or they are community docs, need to have some kind of understanding that someone from their group, either them or someone from their group, should follow up on this patient, because you see, getting these patients from your rehab or out of SNF is going to be a challenge. So if your physician has some partnership, some places have hospice that does the follow-up on the patients. Some of our hospitals, we have an agreement with the physicians who will follow up on those patients. Those does not be part of our program, but not hospital, but they are in partnership with us. So you need to, your situation could be unique, but your challenge perhaps for this program is going to be a very auto-driven model where either some of them, if they belong to a group, should have a follow-up, or if not, then they should have some agreement with a physician who's going to do a follow-up, and how you're going to connect with that physician on day-to-day basis, so you know what's the patient length of stay look like.
Thank you. Next question again to you. For visits that occur within 30 days post-discharge, regardless of reason, do those come out of bundle? For example, seeing specialists that have nothing to do with the surgical procedure?
Yes, they are. So it's follows the same methodology what the CMS does, all calls for admissions from your anchor stay within 30 days.
I believe, Dr. Imran, the question was, does a specialist visit count towards your expense for that episode? That may not be related to the actual episode, the anchor admission itself.
Right, so I got it. So your spend is your spend. Post-discharge from that would be your day, your clock start ticking. So anyone who is dropping claim with the Medicare is going to come out of that bucket. So you have X dollars allocated to a patient, let's say $30,000 to manage that patient, $10,000 is spent on the acute side or hospital side, you're left with $20,000. Now, for that $20,000 is your bucket that sits on the side. Whoever's going to draw that claim, if a patient is seen by a specialist or any person, any admission, anyone who draws that claim from Medicare, if Medicare is a payer for that claim, is going to come out of that your bucket.
Great, thank you for the clarification there. With about the last 2 minutes, I have 2 questions we're gonna ask together here. So it's asking about challenges you faced while implementing this, Dr. Khan, Dr. Imran, for both of you. And then anything else you want to add about something you maybe hadn't anticipated when first implementing this as well?
Dr. Mansoor, I'll pass it to you.
Sure. So, you know, it's always the human element that's the most difficult to manage. So as Dr. Imran has said multiple times, making sure that you have alignment with the physicians is critical. That will make or break your program. And that, you know, that is, so that means the incentives have to be aligned. You have to have buy-in from the physicians. And then you have to be able to track and make sure that they have the appropriate information at the right time, so that they can do the, you know, what they need to do. So that, I believe, is you know, sort of the most critical single thing, if you want to look at that in terms of success, is how engaged your physicians are in making this program a success. Dr. Imran?
Yeah, thank you. And I think just was going through some of the question we made. So one thing also on the implementation side, again, how much of a heavy lift this one is if you're going to do implementation from an IT perspective, and how you better align with your physicians on your post-acute side, so there is a clear visibility on your patient movement as the patient gonna be, I'll say they are your patients for next 30 days. So I think there was one question, is this 30 days or 10 days? It actually is 30 days from the day the patient for the episode of care.
Great.
And yes, the CMS data is available monthly. Yes. Yeah. Sorry, go ahead.
All good. Thank you. We're at the top of the hour now, so we're going to wrap here. Thank you, Dr. Imran, Dr. Khan, for the excellent presentation, as well as Persivia for sponsoring today's webinar. Thanks to the audience for joining us. We hope you enjoy the rest of your day.
Thank you very much. And if you have further questions, please feel free to email us or myself, and we'd be happy to follow up.
Likewise here. All right. Thank you, everyone.